everyone to another webinar of our series Conversations on COVID-19. I'm Hal Ali, the coordinator for Easter Alliance for Global Health Partnerships and Easter Ireland. These webinars take place on Fridays at 1 p.m. Irish time and 12 GMT. Just to not confuse you, I know that some people confused with the summertime change. And we host experts from global health, healthcare, aid and development, humanitarian sectors to share with us their insights and experiences regarding COVID-19. A record of this webinar and the previous webinars as well are available on our website, which are now on the slide on the screen, and also on our YouTube channel. Live stream.
Hello.
Hello.
It's Maggie.
Yeah.
Hi.
Can you see me?
Hi, Margaret. You're in now. It's perfect, and you're live.
It took a while. Perfect. It took a while. Sorry
That's
about
okay.
No problem. You're fine. Thank you for coming. So yeah, the live streaming is now available on our YouTube channel, Irish Global Health Network. Today, we will hear from the experts some lessons learned from previous epidemics or outbreaks such as HIV, Ebola, and cholera. Also, we will know a bit about the role of behavioral science in combating epidemics. Moreover, we will have a unique update from Father Michael Kelly regarding the situation in Zambia. Also, we'll have some contribution from Sudan, which I'm really also excited about because I'm from Sudan. I live here in Ireland, but also I think a lot about Sudan, so also I'm excited for that. If you have any questions during the webinar, please raise your hand, or you can use the questions and answer feature in the screen. And for now, I will leave you with my co-host Nadine Ferris-France, the Executive Director of Irish Global Health Network and Easter Ireland. Nadine?
Great, thanks Hala, and welcome everybody who's joining us. So I'm delighted today to welcome our panelists. We have Kate Thomson, a longtime friend of mine, and she is currently the head of Community Rights and Gender Department in the Global Fund to fight AIDS, TB and Malaria. She has worked in UNAIDS, and she was also a founder of the International Community of Women Living with HIV/AIDS, now called Positively Women. So welcome, Kate, from Geneva. We have Margaret Fitzgerald, currently the Public Health Lead for Social Inclusion and Vulnerable Groups in the HSC, and formerly working with WHO and MSF on Ebola and many different types of outbreaks. We'll be hearing from Dr. Alam Alhuda Abu Kalib, who's the State Minister of Health from Sinnar State in Sudan. Unfortunately, he cannot join due to sanctions on the network connection in Sudan, but we have an audio from him, which we will share with you. Delighted to welcome Pete Lunn, who's Associate Research Professor at the Economic and Social Research Institute. And also Sian White from the London School of Hygiene and Tropical Medicine, and she's a research fellow there on behavioural science. And then of course we have Ruairi Brugha, who's our webinar anchor, our steady in this webinar series. He's a Professor Emeritus and former head of the Public Health and Epidemiology at the Royal College of Surgeons. So I'm also going to share a message from Father Michael Kelly with the situation update from Zambia. So Ruairi, if we can, let's kick off with you as we do every week, just to kind of ground us in a little bit of context about what's happening in Ireland and further afield, particularly in low middle income countries. Thank you.
Thanks, Nadine. So Ellen's going to bring us into our WHO overview, and we'll see that the map of the daily cases has just changed slightly, but it'll show us. We'll say yes, you do want to continue. It's going to show us a somewhat different picture, but the same data. You can trust it, I think. Yeah. So what we'll be seeing when we get into it there, we're not quite in yet, enable editing, is the large blobs. Can we get in, Ellen? We're not quite in there yet, are we?
I'd say we'll catch up with you, Ruairi. Sorry for...
Oh, you're in it, are you? Can you see it?
No, we're going to catch up in a minute. I think she'll probably have to just go out and come back in. So,
or enable editing.
Mm-hmm.
Yeah. So what it'll show is those very large blobs in Europe, in Spain and Italy, the much larger one now in the US. There we are. But what I want to look at is what's happening in Africa. What we saw previously, if we go down to South Africa again, we see, as expected, if you can get down to South Africa there, when you hover over the South Africa circle there, you'll see the number of cases. Malawi just came in there at 8, South Africa 1845, and North Africa also reporting a lot. If we go over to West Africa there and say Cameroon, Nigeria, Ghana, Cote d'Ivoire, you get down around the Gulf of Guinea there, yeah, you see in the region of 300 cases and small numbers of deaths reported. We saw there actually Malawi came up with, I think, 8 cases. South Sudan we'll see with very few, Sierra Leone. And it's what you would expect, not based on what's happening with the epidemic, but how strong the health system is. And that's what testing in Africa appears to show us. It doesn't give us a real quantifiable handle on the epidemic. I compared it to examinations. What do examinations measure? They measure the ability to do examinations. What does reporting, in this case, measure? It measures the ability to test and report. So I don't think this is a good measure, and I think we could look at some of the other measures that will be coming through. In fact, there's one I mentioned later, I came across in The Guardian a week ago, which was, we can start to go into the next slide now, Ellen, as I'm talking. There was a report from Jakarta in Indonesia, and that funerals in Jakarta in the month of March were 40% above any other month over the previous 2 years. And it's just an example of what are the things that we're going to measure that's going to give us a handle on the epidemic. Here, now, we've looked at this one before. We're just looking at weekly trends. I've added in 2 African countries at the bottom. But even if we just look, say, at China, and we look across, this is a successfully suppressed epidemic. There's virtually no change in cases or deaths. As we go down, if you look at the 10th of April on the right, and as we go down there, now we're beginning to see the picture, say, from Italy. If you look at over the period from the 12th of March, we've got 5 weeks there. You see in the first 2 periods, a tripling in cases from Italy, a tripling in deaths. By 26th of March, that was down to a doubling in cases, still more deaths. Deaths always lag behind. They're a much more reliable measure of the impact, but they're a delayed measure. And then as we move to the 3rd of April and the 10th of April, so we are definitely seeing the epidemic slowing down. If you look down to USA and UK, these are later epidemics, badly controlled ones, and we're still seeing very large rises, well above double in cases, triple in the case of deaths in the US. And then we come down to Ireland. I think we lie somewhere between effective suppression and the mitigation phase that we've seen in other European countries. And then down to South Africa and Nigeria at the bottom, you know, and one can take no complacency at the small numbers being reported and the small number of deaths. So let's move on and see. We're going to look at, in the next slide at Ireland. I'm not going to go through this. It's just to say there is a link at the bottom there. It's useful to have these summaries. This one is from the Health Protection Surveillance Centre. The one thing that's there in the bottom left, it's difficult to see. We had to do a screenshot, was the high proportion of community cases. But for people who want to get a handle on how the epidemic is distributed in Ireland, this is useful. And we look at the next slide, which tells us a bit more about Ireland. And what I've put in red there are the things that we should pay more attention to. Not the numbers of cases, but the numbers are, in this case, the percentage of community transmissions. So I've been saying over the last few days, whenever asked, we are not in the place we need to be in Ireland. And what is important in the data is not the numbers of cases, it's the proportion of community transmissions. And we look at local transmissions. We really need to see the percentage of local transmissions going up, and the percentage of community transmissions going down, because that'll mean we are pushing the virus out of the community into households where contact tracing is being done. The number of clusters has doubled in the last week as well, and the numbers of health workers in a 10-day period has almost tripled. So we can be far from complacent about where we are in Ireland. Our ICU numbers at 230 at the bottom. Before we started the epidemic a month ago, we only had 250 beds. We have far more now, but we are rising quite quickly in terms of the impact on the health services. So next slide. So the next slide, I think, is, you see my very bad drawing again on this epidemic curve that we show each week. And what we put in there is, it looks like I had a bad night with that jittery yellow line there. It started to reproduce what the chair of the modelling committee was showing us last week. And those R's are the reproductive rate. So the shape of the curve and the reproductive rate, they're telling us two different things, but they're closely correlated. And this is the estimate that the reproductive rate would be 4.5 infections transmitted by each individual if we weren't controlling the epidemic at all. We're down to an estimate of 2.7, and we're aiming to get well below 1. So that's where we're trying to get to. It's still likely that we will exceed health service capacity unless we really push the curve down. Next slide. So what are the current issues? And this current issues in Europe, but we're going to move on to looking now at sub-Saharan Africa. So as we've seen, early signs that the epidemic curve is being pushed down in the more advanced epidemics. The Irish modelling data is showing that we are heading in the right direction. The daily growth in the virus of 30%, which is equivalent to like a doubling in a week, is down to 9%. We're not where we need to be, and what I talked a bit about on prime time, a lot of it got left out, was what do we need to have in place. Everybody is aware of the regulations around travel and distancing, but these are the other components that need to be in place. A much more efficient testing system, not just the numbers of tests, but the speed at which we get tests done and get results back. Contact tracing, and I'd be interested if anybody wants to talk about the role of mobile phones in contact tracing and some of the measures used in China, which may raise questions around data protection and rights. But we probably need more efficient contact tracing. Surveillance, we've talked about the other bits. So next slide, where are we with our partner countries? And this is just some issues that we covered in the first webinar, and it's worth just putting up in place. And this is just some of the elements of that we might consider for effective COVID-19 control in our partner countries. The emphasis on we can't protect everybody if we're really short of PPE, but we really do need to prioritize health workers. We can't measure to the same extent as we're measuring in Europe and as they did in Korea and China far more effectively. But we do need to be measuring to have data to advocate for resources. So I'd be interested to hear what people can report and from the panel around measuring hospital data. Is there any evidence that we're getting data now to show the impact? The deaths and burials, as I mentioned. I've been a little bit sort of pouring cold water on how can we actually tackle the epidemic. But I do think we need to look at measures such as oxygen. I do a lot of research on surgery in Africa, and hospitals do have oxygen. And maybe that's something that can be scaled up if we move quickly. But don't be putting too much attention on things that can't be scaled up. Respirators require very skilled staff. Avoiding doing harm. We mentioned about lockdowns before. I'd be interested to hear what's coming back from the panel and from countries. And I'm just throwing this one in at the end because the DG WHO poured cold water on it. I know it is a sensitive issue, vaccines, but I do think we have to look at all of us working to produce a safe, effective vaccine. And Africa and Asia are actually very well placed for conducting these trials. Next slide. These are just some of the measures that we talked about in the first webinar: the importance of maintaining and protecting essential health services and other essential health programs, and more generally looking at the secondary effects of the epidemic, which I think that's a theme that will come up today, could end up killing a lot more people in Africa than Ebola will, or than COVID-19 will directly. And final slide, I think. Yeah, this is just, we talked about the operational guidance from WHO, and here are, this was a particularly useful guide on how to protect our essential health services. So let me leave it at that. I think that's the end, and over to you, Hala and Nadine.
Thank you, Ruairi. Thank you for that. Starting to be very grateful for these updates once a week, start to get the get a flavour of where we're at and how things are moving, and thank you for continuing to raise the issues that we need to be focused on. So we're just going to move, you know, the focus of this webinar today is really to look at some of the lessons that we can learn from, you know, from HIV, from Ebola, from other diseases and epidemics that we've been working with, and also to focus on behavioural science. So I wonder, Kate, if I could come over to you. And again, thanks for joining us on a holiday. I wonder, Kate, could you tell us a little bit about what you remember from the early days of HIV? You know, because there's kind of many things that are kind of reminiscent of this here now for COVID. Yeah.
Thanks, Nadine, and it's a pleasure to be with you all here today. So yeah, I was diagnosed with HIV in at the beginning of 1987. So it feels like, and it is a long time ago, and I was actually joking with a friend last night, it feels like we're having to survive another plague, and we're all hoping that COVID doesn't take us out when we manage to survive HIV. Yeah. But you know, back in the day, I mean, HIV was a relatively new disease then, so there was still a lot of unanswered questions, as with COVID. There was, like with COVID, no treatment. People, friends, colleagues were dying often on their own, without their families, similar to COVID in some ways. People were being placed in body bags. Hospital workers were wearing protective gear. I remember having to go into hospital and people, you know, dressed up to the nines like we're seeing now. It's bringing back a lot of memories, really. You'd find people would refuse to shake your hand or eat with you. So that distancing, even though actually we know it wasn't appropriate or relevant for HIV, it was still there. You know, people with HIV were being very much put in that place where most people wanted to distance from us, from them. There was a lot of misinformation out there. I mean, those of you who were around then will remember, you know, views that, you know, people saying you could catch HIV from mosquito bites and so, all those kinds of things. But at the same time, there was no internet access. So we weren't, you know, there wasn't this constant deluge of information that was coming through, you know, telling you, oh yeah, but if you drink hot water every few hours, you'll be fine, and all the rubbish that we're seeing now. In fact, it was the other problem. There's very little information. In the UK, we had, you know, the big Tombstone campaign, but, you know, stigma and discrimination was rife, as were breaches of human rights violations for those of us living with HIV, either because of our HIV status, but also often because many of us who were impacted by HIV were already in groups, parts of groups that were already marginalised, often criminalised, and not valued by societies, which in a way is slightly similar to looking now at the key workers who've been undervalued for a long time within the context of COVID. What we saw back then was the tremendous power of communities in terms of self-organizing, supporting each other, coming up with creative solutions, including for HIV prevention. For instance, the whole concept of using condoms as a form of safer sex was which was a different form of social distancing, if you like, but physical distancing. But it was something that came, you know, this was coming from communities themselves. Also, I think for us, the importance of advocacy and speaking out about our experiences and putting the record straight, and holding our leaders to, you know, to account, our governments to account. The support, the incredible importance of peer support, of listening to, being able to listen to and support others in the same situation, who had often lost their families, were on their own. And then the last thing around this is, you know, in the slightly less early days, around 1996, when treatment really became available, by that time we'd forged very strong connections and relationships between people with HIV in the, you know, in the north and those in the southern hemisphere, and we had sort of till that point all been pretty much in the same boat, even though those of us who were lucky enough to live in places where there were strong health systems, you know, we could get easier treatment for, you know, opportunistic infections and so on and so forth. But when treatment became available, that great shift between our access to health and the access for others really widened, and it's something that I think that I'm mindful of as COVID moves forward, how that's going to happen. We're already seeing it in terms of the strength or lack thereof of health systems. But yeah. I'll stop there now.
Well, yeah, and maybe just as a follow-up, Kate, it's really interesting just to hear your personal perspective, and it just really reminds me of the early days of HIV as well. And you know, I just think now in your position in the Global Fund, you know, you're in this position at the moment, and I'm just wondering, you know, what do you think are the main kind of lessons for us to learn for institutions and organizations like the Global Fund? What should we do? What should we not do? And I know it's early days, but you know, what kind of things are coming from the Global Fund at the moment?
So, well, from the Global Fund specifically, we're really, I mean, we have been over the last few weeks working probably, you know, at least 50% more than we were working before, because not everything, but a lot has switched to COVID. So we're trying to ensure that we maintain the gains that have been made in terms of HIV and TB and malaria as much as possible, while being mindful of that, you know, unless we're also looking at COVID and supporting COVID responses in the countries where we're working, then, I mean, it just makes no sense. So as a fund, we put in a lot of flexibilities in terms of what countries are able to ask for, and reprogramming of funds and using of savings and so on and so forth. But it is going to be a very moving target, I think. I mean, once we have, you know, I think we're going to, as I mentioned before, in terms of just treatment access, I mean, one of the things we are seeing is, you know, we heard it just now, you know, I mean, like testing, I mean, testing's not happening in the UK. My mother's been extremely sick. My husband's mother's been extremely sick. Neither of them have access to tests in the UK. So I mean, it's not just there, but I think at least there are some systems in place. But as we get, once we have effective antibody tests as well, I mean, once hopefully there is a treatment or vaccines available, we need to ensure that, you know, those are reaching all of the countries everywhere. We need to get the right information out there, critically important, really working with communities and others to ensure that the right information is out there. We need to be mindful of and one of the things we're doing at the Global Fund is really, and again, this was referred to before, being mindful not only of the human rights and gender-related barriers to access and to responses, but also how we do no harm, how we protect human rights within COVID responses. And we don't let go of some of the gains that have been made in HIV over the last years. And, you know, how much are we as you know, as communities, as nations, willing to let go of some of our privacy, and where does that line stop in terms of public good versus our, you know, like protecting, you know, our own personal data. And I think, I don't know, we're going to have to, you know, it's that ongoing focus on the right to health for everyone, you know, universal access, meaning leaving no one behind, whether it's HIV, TB, malaria, or COVID, and including those with less power and influence in the responses. It's going to be critical.
Thank you, Kate. No, it's amazing. I think we just have so much to learn from HIV, especially in terms of gender and rights. So wonderful wonderful that you guys are there and bringing those lessons across. Thank you for that. And I see that for Breda, thank you for your comment, just supporting what you're saying, Kate, in terms of making sure that that there is support for those who are recovering and affected from COVID, both say here in Ireland locally and also globally and among our partners. So thanks for that, Breda. Okay, great. I'm going to come to Margaret if I can. Margaret, you've got quite a lot of experience in many different epidemics over the years with both WHO and MSF. And I just wonder specifically today if you could just focus on, what are some of the lessons that you think we could learn from the work that has happened on Ebola? And I know you have first-hand experience on that.
Okay, so actually, when I was thinking about today, I was thinking about not just Ebola, but the very first outbreak I ever got involved in was in Sudan in cholera. And it was well before many people's time in relation to Live Aid. And when I went to work, and that was with Goal in those days, when I went out to work in Liberia in 2014 with the WHO Global Outbreak Response Team, I think the first thing I learned in August, and it was just before the peak, it was at the stage where it had entered the city of Monrovia. And I can only say that early August 2014, the situation was chaotic. And the first thing I heard coming in from the airport was that the president had enforced a notice of quarantine. And the quarantine was imposed on the citizens of West Point, which was a slum of Monrovia. And if ever what not to do was the case, that was what not to do, because they effectively locked in 100,000 plus people into an area the size of Dunleary. And the whole situation became very fraught. So the people who most needed help were those who got at least, and the food situation was very critical for those people. Yeah. So I think some of the early lessons in terms of the outbreak was of Ebola, first of all, the transmission was very much more specific, but it did include some aerosol, but it was mostly touching and bloodborne and secretions, body secretions. So funerals were a huge point of a source of transmission. The outbreak, the Ebola outbreak, really indicated the weakest link, and the health service were definitely the weakest link, and very rapidly the health services collapsed. And when I arrived at the midpoint or in the early point of the peak, the health services in the city of Monrovia were virtually collapsed. There was the main treatment centres belonging to the government were in the cholera ward of the Central Teaching Hospital in Monrovia. So the NGOs really were the ones that had to provide the treatment centres, and MSF were one of the main NGOs that opened treatment centres, and essentially to support the collapsed health service. And like what we've seen here in Ireland, the healthcare workers, that was the biggest problem. Healthcare workers, when they got infected, became very fearful and also died. And so therefore, supporting the healthcare workers didn't happen enough, and also was seen to be very important later on. Mm-hmm. One of the other issues was that I mean, apart from the whole coordination of the response, that was chaotic too. There were so many agencies, so many players, so many NGOs, all the government departments, and a weak government system trying to coordinate all the actors, was very difficult. So we had like 9-hour meetings at WHO, and I think we're bad here with our teleconferences that go on forever. I think it's worse now. Actually, I do agree, the social media, the emails, we never got that flood of email. Yeah. But one of the other issues that I feel, a very strong message in terms of what to do if you're sick, what to do if you want help. And in fairness, Liberia got the message very quickly out. They said, phone 4455, quick. And the unfortunate thing about that message, and we've seen it here, when we tell people to go out for tests and we tell GPs to test, and then we couldn't back it up with testing. In Liberia, people were told to phone 999 or 4455 and they mightn't get an ambulance call out for 3 days.
Right.
And then if the ambulance did call out, there was no room in the inn. There was no place for people to go. So I mean, that was very frustrating. Contact tracing was absolutely just literally, how do you contact trace in a slum? How do you contact trace with a weak health system? It's one of the huge challenges in Ireland at the moment. The contact tracing system is constantly being looked at again, and in a very weak health service, it's impossible to contact trace.
And Margaret, would you say
the community are the answer?
Yeah, and I mean, just talking just on a last point around, those who are most vulnerable, and I'm sure you saw this with Ebola and cholera as you're describing there in Liberia, and in the other countries you were working with, how to support the most vulnerable people based on what you've actually learned from these epidemics?
Well, yeah, I mean, in terms of cholera, the most vulnerable, the infants, the babies, and then with Ebola, it was huge swathes of the population. And here, I think we'll find that those who need it most can access it least. So, and therefore, and trying to find them. So how do the most vulnerable self-isolate?
And that's even an issue for Ireland, right, Margaret? You're at the moment heading up. Yeah.
So I think what I saw, how people responded in Liberia was community with community support, and WHO had a very good community support team. They got their act together. They figured out for themselves what to do in terms of isolation of cases. They improvised their own PPE in black plastic bag. So, and then they got it. They got what to do, what not to do. So I think with our vulnerable groups, it's very hard. We have the travellers, the Roma, the people in direct provision, the homeless. And what this outbreak is showing us is our weakest links.
Right.
Because here in Ireland, those who have homes can self-isolate. Those who have GPs can ring their GPs and get a COVID test. But
our most vulnerable people cannot.
We're working very hard to try and, connect all those pieces. And we have huge efforts going on. But it is a big challenge.
Yeah. Margaret, thank you. I'm going to leave it there and come back to you again, but thank you so much for that perspective. I'm going to move along to, if we could hear from Dr. Alam Alhuda. We have an audio message from Dr. Alam, and he's going to talk to us a little bit about the situation in Sudan. So we asked him similar questions just to update us on what the situation was and some of the lessons learned from Sudan dealing with, for instance, epidemics like cholera.
Hello for all. I'm Dr. Alam, DG Minister of Health, Sinnar State. The COVID-19 pandemic has already spread to more than 100 countries around the world. These include countries whose health systems are fragile and very weak, like Sudan. COVID-19 pandemic is a defining global health crisis of our time and great challenges we have faced since World War II. No data available of another mode of transmission and viral behavior and rule of whether a relationship between malaria and other epidemic disease and coronavirus. The situation in Sudan, currently the confirmation cases, 15 cases and 2 deaths and 2 recover, and 2 case community transmission and 13 case history of travel out of Sudan, more than 200 suspected cases in the whole center in the Sudan. Key issue of epidemiologists is helping policymakers decide the main objective of mitigation, example, minimize morbidity and associated mortality, avoiding an epidemic peak, the overall health care service, keeping the effect on the economy within a manageable level. the key lesions of cholera that can help us win against COVID-19 in Sudan. Just slow down the virus by a simple way and low cost like complete lockdown and physical distance and other behavior practice, and currently the most effective measure to reduce the risk of transmission, and then protect health worker and repurpose resource to support epidemic response and community health worker and psychological support. But it's still challenging in Sudan. The pandemic in Sudan is moving like voice of the tender, one that may yet crash and those less able to cope. The case fatality rate high. At least some of those people infected can transmit the disease before developing symptoms or even the absence of any symptoms. In addition, very high proportion, around 8% of people develop a very mild form of disease, no discover, and become source of transmission. Then confirmation and diagnosis require laboratory and medical imaging, and staff are not available. And the epidemic then is very different from those such as measles and cholera, no full data for study. 15 to 20% of the patients with COVID-19 require hospitalization, and 6% require intensive care for a duration of between 3 or to 6 weeks. And this is more difficult in Sudan because collapse our health system and more ventilation in the Sudan, 300 just. And people in Sudan must often walk for hours and even days in rural to reach the nearest health care facility, while less than half of the health care facility in the border non-functional, as often the case during this type of the pandemic. Medical staff members themselves are particularly exposed to infection, and no BBS available, and economic states in the Sudan. Every day people are losing job and income and looking for food and water with no way of knowing when normality will return. Lots of the challenges, but civil war in the Sudan and country around affecting the health situation in the Sudan.
Thank you, Dr. Alam, for updating us on the situation there in Sudan. Just moving from Sudan, I think it's appropriate just to share some words that were shared with by Father Michael. So Father Michael Kelly, as most of us will know, born in Ireland but living in Zambia for over 50 years, working on HIV and AIDS and education. He sent some words in to us this week. He basically talked that in Zambia there were 39 confirmed cases and 1 death. Until now, the situation, COVID has been affecting people who could afford to travel abroad, so people in better off categories, and it hasn't yet gone into the local population, among the 60% of people who live below the poverty line. And of course, the fear, these protective measures are quite difficult to try and, enforce social distancing. People love to shake hands in Zambia, and we have Easter coming up, and in Zambia, people are very religiously minded, and it's very difficult to not be going to church. He also shared that there's a doctor-patient ratio of 1 doctor for every 12,000 patients. And that falls very much below what WHO recommend, which is 1 doctor per 1,000 in the population. So clearly, even if, in a general coronavirus epidemic within the country, Zambia wouldn't be able to respond in terms of medical personnel. It wouldn't have the infrastructure, the transport, the testing, or the care facilities to deal with a major epidemic. He also shared that although in Zambia at the moment there's not a medical pandemic right now, he's saying that they're experiencing already a severe and a very adverse economic virus-related epidemic. So the mainstay of the country's economy is copper, and the biggest customer there is China. And of course, with the decline in global economy, in particular China, it's resulted in there being less demand for copper and a reduction in its price. So in terms of, what that means is Zambia won't generate the revenues needed for the economy to survive and pay off its debts. And in a country that's already saddled with heavy debt burden, this could lead to debts becoming unsustainable at a time when the possibility of corona epidemic is leading to unanticipated increases in health spending. You know, the tourist industry, he just mentioned as well, another economic mainstay, it's almost been wiped out already by the impacts of COVID. Air travel is curtailed, hotels are closed, Victoria Falls, the main tourist attraction, is not accessible. And always, just coming back to HIV and, you know, a little bit to dovetail what Kate mentioned, he just reminded us that in Zambia, the infection rate of HIV is 11.3%. And although most of the people living with HIV are on treatment, it's likely that if the country had to deal with a significant corona epidemic, the health system wouldn't be able to cope and wouldn't be able to continue to provide universal access. So I think that's just a really interesting perspective from Zambia, just following what we heard from Sudan. So thank you for that, Father Michael. I'd like to move over to Pete, if that's okay. So just to change a little bit in terms of behavioural science, it's something that many people are becoming interested in these days. Pete, I'm sure you're finding a lot of people are knowing a lot more than before. Can you tell us a little bit about how behavioural science has helped us in the past deal with outbreaks and how we can use it to combat this kind of an epidemic?
Yes, I can try. A quick disclaimer, I mean, I'm not a public health expert. I'm a behavioural scientist. I mean, we do work on health choice in our lab, but it's usually things like physical activity and diet, not dealing with disease and pandemics. And a lot of the work we also do is on things like financial products. But what unites the work that we do as behavioural scientists is that we look at human decision-making and behaviour. And there are regularities across multiple domains in how humans behave and make decisions. And we realized quite quickly as this disease spread that the expertise we had was relevant. So we went diving into the available literature to try and synthesize a lot of evidence in behavioral science. And a lot of behavioral science has been done in relation to coping with disease outbreak. I mean, we found quite quickly more than 100 relevant papers. So rather than pick out specific findings that are relevant, I think I'd make some observations across those papers.
Great.
And one of them is that as a behavioral scientist, one of the themes you find across all domains, whether it's health or finance or anything, is that the authorities concentrate overwhelmingly on providing citizens with information and education, in the belief that giving them information and education is the primary route to changing people's behavior. And the problem with that is that from a behavioral science point of view, it's generally not true. Information and education are hugely important, and I wouldn't want to suggest anything otherwise, but they are very, very rarely sufficient to change people's behavior. What you need is changes to the physical and social environment that help them to behave in the ways that the information and education suggest are the right ways to behave. And so a particular example of that is hand washing. I mean, there's a lot of evidence on hand washing, and I know your next guest is going to talk more about this, but I mean, the one thing I would say briefly is that hand washing is very much an habitual behavior. And in order to break that habit, it turns out that education information is simply not enough. What you have to do is grab people's attention. There are simple, cheap interventions that all organizations can put in place that grab people's attention at the right time by the way signs are put in place, by the way the facilities are organized, that mean that simple, cheap interventions can dramatically increase. And by that, I mean large effect sizes in the number of people that are using hand sanitizers or washing their hands properly. So grabbing attention is really important. There's also issues like self-isolation, which has been mentioned, where we found good evidence, and we've actually taken evidence ourselves from an experiment in Ireland in the last week, actually, that you can change people's willingness to self-isolate by getting them to do some planning beforehand, because it increases their confidence and it makes them feel that they can get through a period of self-isolation better. So simple psychological interventions that change people's focus, change their attention, and not just about information and education, but change the environment in which they're operating, can be very effective.
And Pete, I know, you know, there's no easy answers to this, but I think one of the other things that Father Michael said in his article, which is available online, it's in the chat link if anybody would like to read the whole article. You know, you're talking about in low middle income countries, settings, for instance, where people are living in very small dwellings, large numbers of people, no running water in houses, hand washing methods, you know, trying to wash regularly with hands, people who are hand to mouth in terms of, you know, going out that day to generate the income income they need to feed their family that night. What, you know, what if anything has the evidence said, or what do we know that could help?
Okay, so I mean, I'm on the edge of my expertise here in the sense of not having done behavioural studies in those kind of environments. But one of the things that's very interesting is that some of the evidence does come from very difficult environments in which to contain disease. And there are some principles that apply across multiple environments that I think are really, really important here. I mean, one of the most vital things during a disease outbreak is collective action. It's the fact that individuals need to behave in ways not just to protect themselves, but to protect society as a whole, that one person's behavior affects the likelihood that other people catch disease and so on. And behavioral scientists know a lot at this stage about how to promote good collective action across multiple contexts, including very difficult and awkward social contexts in developing countries. And what we know is that if you want people to behave in ways that are collectively good, even in very difficult circumstances and in crises, the clarity of the message for why the behavior is best for all and how often that message is communicated is vital. That's the first thing. So there's kind of clarity. If we all do this, we'll all be better off. The second thing is building a degree of team spirit and group identity. So the greater people feel like they're part of a group that is fighting something, the more likely they are to engage in those behaviors. But the final thing is there has to be a degree of social disapproval for those who don't do what they're being asked to do. For those who are letting down the rest of us by not engaging in the behaviors that we need them to engage in to prevent infection, there has to be a degree of sort of, not over the top, but there has to be a degree of punishment from the rest of society, even if it's a simple social disapproval that picks people up on stuff and tries to bring them in line. And what the behavioural evidence would tell you is that those things can foster a much greater collective effort with people making sacrifices for each other.
Thank you, Pete. Very interesting. And just in kind of a last point is in terms of Ireland, how do you think we're doing in terms of you know, those measures you just described? As a you know, living in Ireland, I think that's what I'm seeing, that's what I'm hearing. How do you think we're doing?
I think we're doing better than most of our neighbouring European countries, from what I can see from the behavioural data I've seen. And I'm not an epidemiologist, but I think we're doing better than we thought we might be doing. And I think part of the reason is people's behaviour. So I'm cautiously optimistic that we're doing okay. You know, I'm very mindful of the first presentation we saw from Ruairi, which gives me lots of pause for thought in that regard. But I also, I mean, I have a lot of friends and colleagues who are working in Britain and in other European countries where I think the degree of solidarity and the degree to which people are complying with advised behaviours is frankly lower. I think part of the reason for that is because of the way we've gone about it here, which I think has been good. But we also have an advantage, which is I think Ireland is a small country and it's easier to do it in a small country. And I think we have quite a cohesive country as well. We're not as politically polarised as some of the other countries that are struggling with it. So we have some natural advantages too.
Thank you, Pete. Thank you for all you're doing. That's really, really interesting. I wonder if I could move then to Sian, who's in the UK. So not so far away, but quite a different context at the moment. And Sian, I wonder if you could tell us a little bit around, you know, what are some of the factors that enable or prevent people from simply washing their hands, given that washing our hands is the most important thing we can be doing?
Sure, thanks very much. And obviously the challenge with being the last speaker on a session like today is that all of my, you know, my colleagues Pete and Margaret and Kate and Ruairi have done such a top-notch job of already flagging a lot that we can learn. So I spend a lot of my time thinking about hand washing, which obviously makes me feel very in vogue at the moment now that everyone is talking about it. So, I mean, as Pete's just explained, with any behavior, we really see the determinants being not just one simple thing, but across a whole kind of universe of factors. So ranging from things in cognitive factors to factors in the environment to social norms. And it's really key for anyone designing hand washing promotion programs to think about that whole universe of determinants. But often we unfortunately don't see that. So often if I pose to people the question, well, why do you think people don't wash their hands in your community? The classic response that I get is, oh, well, they probably just don't know, you know, the benefits of hand washing. Or even if they do know, maybe they're just being negligent. Or, you know, it's probably just not part of their culture. And I think it's really clear that none of those have have any substance to them, because what we're talking about here is really not a behavior that's in any way new. So people across the world, even in settings where there is relatively low levels of formal education, people still know that there is a clear link between hand washing and health. And indeed, like, hand washing has been around in our culture and in all cultures for centuries, long before we understood about germ theory. Soap itself has been around since 2800 BC. So this is nothing new here. Right. And it's always important that we keep that at the front of our minds when wherever we're responding to an outbreak like this, simply because it's very easy to be condescending to people who are struggling to cope with this very new situation. So it's really critical that we think about all of the determinants. We've just done a quite large systematic review on hand washing behavioural determinants, and it really echoed what Pete said, which was unfortunately there really isn't a link between knowledge about health and hand washing and actual behaviour. So whilst knowledge is critical at the moment in understanding this new pathogen, it's going to not be sufficient. And what we found is the most powerful driver of hand washing behavior is probably no surprise to anyone. It's having convenient, desirable hand washing facilities available with soap and water. And that's something we can easily take for granted, you know, here in London or there in Ireland. But it's something that the majority of the world simply don't have. And so that's why, you know, we're seeing renewed calls from the WHO in the last few days to make sure hand washing facilities are available in the entrance to every single building, in any public transport facility, and in any other place where people may gather. And I do really think that's critical. There is also a tendency in outbreaks for us to over-focus on risk and fear and you know, these disease perception factors, when all of those other determinants that drive hand washing behavior are still at play.
Yeah, thank you. Thank you, Shannon. I see just something coming in from Eric there, just in terms of 3 community spread reduction ideas. One, grabbing attention frequently, you know, high-vis stickers reminding people, you know, with good messages. As you just said, Shannon, universally accessible, free outdoor public hand washing stations. And then that, as I heard Pete also say, just public information, you know, being, you know, said again and again and again. I also see in from Maeve there, who's in Mayo, that in some of the high income settings, this is for you, Pete, that we're still observing some health workers who are, you know, forgetting to maintain social distancing in the tea room, using face masks in inappropriate clinical environments, and still meeting face to face because of the stress that's kind of associated with going online. Any comments on that for you, Pete?
You will always see in all these circumstances some people not complying. I mean, the comment I would primarily make is how important it is we get the message out, that we pick each other up on non-compliance, that where colleagues don't comply or where family members or friends are not complying, that we pick them up on it and we remind them of what they're supposed to be doing. One of the things that's really important about these collective action problems is that they can break down, and the behavioural science of this is pretty clear. If individuals see other people not doing what they're supposed to do, most of us are what are called conditional cooperators. We will make the sacrifices and put in the effort if we see that everyone else is. If we see some people not doing, then some other people stop bothering, and over a period of time, the collective action breaks down. So it's vital, and we know this from the science of it, it is absolutely vital that we pick people up on it when they're not doing what they're supposed to do, and that we get the message out that that is okay. You know, we should do that politely and constructively, but we all need to be trying to do it. That is as important as some of the behaviours that we have to do ourselves.
Yeah, thank you, Pete. And I also see, Eric, just to be absolutely clear, you're saying that those stickers, high-vis stickers, should be on or next to high-use handles and buttons, so not just general messages. So, so thank you for that. I think there's a lot of, you know, different comments coming in from people. You know, Niall is saying, you know, how do we sustain behaviors, these kind of behaviors for months on end? You know, it's okay in this kind of an emergency type of time, but how do we continue? And I think, you know, is collective motivation the best motivation for that? And Brita is just talking about, you know, how can we keep people corona free and save lives when countries, you know, when the lockdowns are in play, and also when the lockdowns start to stop? How do we put the vulnerable and poorest people first? I think, Ruairi, I'm going to come back to you if you're still there. There you are, Ruairi, great. I'm going to come back to you just for a final comment, really, because I think sometimes at the end of these webinars, we just, just to bring us back together, maybe to hear a final word from yourself, and just to say that I think, solidarity and just what we've heard from Sudan, what we've heard from Zambia, what we're hearing from Ireland, and hearing from Kate in terms of the lessons over the years on HIV, solidarity remains something that we all have at our disposal, and something that we can all be part of. Ruairi, I could just come to you maybe for a final comment.
Thanks, Nadine. I see COVID-19 as a public health challenge, and I'd like to just raise issues that we may need to come back to again, but we have seen from China and maybe an extent some other Asian countries, measures being used that may have made a lot of the difference in terms of getting to suppression. Our ways of doing contact tracing are very traditional ways of doing it. It has been suggested that the mobile phone, the proximity, the ability to identify those contacts very quickly may be the difference between ongoing transmission and being able to curtail it. Now, there's two ways in which mobile phones can be used. It can be the aggregated data that might give you an idea of overall behavioural patterns, which could be done. I think there's somebody who wants to come in. No, he doesn't want to come in. Or it can be actually monitoring individual behaviour. And I think there are issues there that we need to look at, because it's about, it can be around social control. But if these are the ways that actually distinguish between us falling into an ongoing epidemic that we're not controlling, or one where we're temporarily maybe allowing the state to take on more control in terms of surveillance, and they've gone further in China and used it for social control of individuals. Are these measures that we want to consider? Because the power of monitoring social media and monitoring telecommunications is considerable. And I think we need to start having those debates around the ethics and the ethics of not doing so.
And thank you, Ruairi. And I think that links also to the points that Kate was making around rights, and where is the public health and rights, and what do we know from years of walking a fine line with HIV and other epidemics. So I just want to thank everybody. I want to thank Pete and Sian and Kate and Margaret and Ruairi yourself, and also I want to thank Father Michael and Dr. Alam for all of the inputs today. And we're going to continue this conversation. Hala, is there anything you'd like to share?
Yes, thank you to all the speakers. It was really a lot of lessons that we have learned today. And just to tell the audience about our coming webinar, it will be about the NGO perspective and how they can best respond. We are inviting many guests from different NGOs. So thank you again to the audience. Thank you, Nadine. Thank you for the speakers. And this webinar is recorded, and the recording will be available in our websites on the screen and also in our YouTube channel. And don't forget to also check our portal, COVID-19 portal. And the evaluation form is in the chat. Can you please just help us by filling the evaluation form? And yeah, see you next week. Thank you.
Don't forget to wash your hands. That's what I hear from Pete and Sian and others.
Yeah, the main thing, I guess, the main.
Thank you, everybody, for amazing efforts. Yeah.
Thank you.
Thanks.
Bye. See you next